think at this point, I would like us to start. We're very grateful today and privileged today to have Dr. Zipporah Gathuya once again as our presenter. Dr. Zipporah Gathuya is a consultant pediatric anesthetist, one of the pioneer pediatric anesthesiologists in this country. She has many hats, and recently she has gotten into don another hat in public health. So she's going to take us through this topic entitled Access to Safe Surgery and Anesthesia. We're also privileged to have Novartis as our partners for today, but we'll give them some chance after Dr. Gathuya's presentation to tell us more about themselves. So without much ado, I would like to invite Dr. Gathuya to take over from here. Karibuni. Dr. Gathuya?
Yes, Nganga. Let me share my screen.
Sure. Yep, we can see you.
You can see my screen?
Yeah, we can see your screen.
Okay. Thank you. Oh, I think I must say that was a very nice introduction, Nganga, because indeed it looks like I have yet again gone ahead to start a new field like I did for pediatric anesthesia, but this time for public health and anesthesia. And I must say, for most of us, it's different. We've had a lot of clinical scenarios that have been presented in the last few meetings. But once again, like I did last time, I'm presenting something that sometimes we don't think about, but some of the things that are going to make a difference in our practice of anesthesia as a public health domain. So one of the things that we have to do is to define what is access. So we are talking about access to safe surgery and anesthesia in Kenya. So the first thing we have to think about is what is access. And when you look at the definition, access is simply being able to get what you need. And when it comes to the definition for access to safe surgery and anesthesia, the WHO and the Lancet Commission have gone ahead to include not only being able to get what you need, but to get it in a timely manner, to get it with appropriate workforce and infrastructure, to get it in a safely manner, in an affordable way. So those are 4 pillars of what access basically means. We shall not talk about timeliness. We shall not talk about surgical capacity. We shall not talk about affordability. Those are things that we can talk at a subsequent meeting. But today we are going to talk about safety. So you ask yourself, why is access important? For people to get access, it means that you are able to promote and maintain their health. You're able to prevent and manage their diseases. You're able to reduce unnecessary disability and premature death. And you're working at achieving health equity. And we shall see what health equity entails subsequently. But when we come to Kenya, and I'm sure most of us as anesthesia providers, you don't know that what you do has constitutional backing. So I thought I would take us through a bit of constitutional background. And then we have 2 things that we need to be aware of as we practice anesthesia and as we think about access to safe anesthesia. And one is Article 43, 1A of the Constitution, which provides that every person has a right to the highest attainable standard of health, which includes the right to healthcare services. So that is embedded in the Constitution. Then we have the Kenya Gazette supplement of 2017, which further alludes to what this means in a nutshell. So what are the guiding principles? So I don't know how many of you have seen this document, because I know in anesthesia we are very keen to read clinical books and the like, that we ignore these things, but they are very important because these are the guiding principles. So what are the guiding principles for our practice of safe anesthesia and surgery in Kenya? And one of the documents that has highlighted a lot of how health will be taken in this country is the Kenya Health Sector Strategic and Investment Plan, which is a strategic plan which was made in 2014 to 2018. And this was for transforming health, accelerating attainment of universal health coverage. I'm sure most of us have heard about universal health coverage. But what does it really mean? So this whole thing. So we have the global health, which together with Vision 2030, I'm sure all of you have had Vision 2030. And the Vision 2030 has the Kenya Health Policy, which runs from 2014 to 2030. And this is where the first medium-term plan for health, which is the what document we were looking at. And this is how the constitutional and legal framework, if you can see that flow chart, that is how it can run. Just give me 1 minute. I sort out my house. Please go upstairs. I'm in a meeting. And go to the bedroom, please. Sorry about that. Okay, so this is how it goes. So from here, then we have to look at what are the thematic areas that we are looking at. So one of the things that you have to look at is when it comes to the rights and fundamental freedoms. These are the areas that are directly related to health. And what are the requirements or the relationship of the devolved governments? And how do these two things merge together to form a coalition that can deliver the highest attainable standard of health for all these people as we know it? So there are very many things that you will see here. And when you look at what are the functions of the devolved government, what are the schedule of what is the fourth schedule of assignment of functions? And what is, just 1 minute. Sorry, boys will always be boys. No. So, and the fourth schedule of assignment of functions and what all this means to the health sector. I would really advocate for all of us to read this document so that then we see where we are coming from and where you're going. And then you'll be very surprised to know that okay, so my screen won't move. So Catson, how do I make it move? Oh, good. So then you come to the health objectives. So these are the objectives that are set out in the Kenya Health Policy on how to attain the strategic objectives. So if you look at these objectives, there is nothing that is hinting towards anesthesia or surgery per se, other than reduce the burden to violence and injuries. So, and these injuries, what got into there is mainly road traffic accidents, because there were quite many. But if we were to look at where we would fit anesthesia and surgery, it is in the reduction of the burden of communicable conditions, because most surgical conditions are not communicable. But you see, it is the policy for Kenya that does not recognize the importance of surgery or anesthesia. And this is where now people like us have to come and get out of the operating room and go into public health and be on the table when these things are being done. Then maybe we can push for inclusion of anesthesia and surgery. This is a busy slide, but the purpose for putting this slide here is to show you the service delivery priorities. There is nothing there about anesthesia or surgery. And again, like I had said, if you look at top causes of mortality and morbidity, road traffic accidents are there, and that is why it has made there, and that is where maybe you can put anesthesia and surgery there. So we really have a lot of work to do to move surgery and anesthesia into a level where the country recognizes how much they need to prioritize safe anesthesia and surgery. And one of the things that has happened now is that COVID has come and people have all over a sudden realized that there's something called critical care and we are very far behind in it. And they have been looking for who are these people who run the ICUs, and they've realized actually it's supposed to be in our setup anesthesia, and they're just not there. Who are these anesthesia people? So maybe in a way it was a nice thing. But the purpose for putting this right there was just to show you how we are not featuring anywhere in the priorities. So, and this is just a map. I'm sure most of you have seen similar maps about access to surgery by country. And you can see, if you look at Kenya, we are quite in the place where a lot of people don't have access to surgery. So to start this talk, now we have finished about the background. Now we can talk about why is this an important topic. So if you look at the Lancet Commission for 2015, about 5 billion people in the world lack access to safe, affordable, and accessible surgical and anesthesia care. So that means more than 2/3 of the world population doesn't have access to safe, affordable, and accessible surgical and anesthesia care. The other thing we need to know is that of the total global burden of disease, 11% of that burden is amenable to surgery. So when you come to how can we improve the quality of surgery and anesthesia, then we really have to do capacity assessment and to look into ways of improving access and to have a way to benchmark from where we are, where we are going. So this is very, very critical. So I carried out a study, and this study was to investigate the capacity of level 5 county referral and level 4 health facilities to deliver safe anesthesia and surgery. And we're using the WFSA facility assessment tool. And we got a master facility list from the Ministry of Health. And it is good to know that of the top level hospitals, about 80% can deliver some safe anesthesia and surgery. So that is not too bad. So what were the factors that influence outcome? And some of these factors include infrastructure and equipment. And this infrastructure and equipment has actually come to the fore again now during COVID. And one of the things that you may be interested to know is that the same facility assessment tool that WFSA developed has been used with a few tweaks to make it a critical care facility assessment tool. The other factor is workforce. And workforce here, we are talking about physician, anesthetist, non-physician anesthesia providers. We are talking about nurses. We are talking about biomedical engineers. We are talking about lab people. We're talking about theater technicians, the whole workforce. And the other thing is, how do we strengthen our health systems and how are the processes that are working? So these were the things that I was mainly looking at to see how they help to improve or impede surgical outcome. So what was my epistemological approach? You realize that when you do public health, you must think about where are you viewing this thing from? So I would say that this was realism with positivism, because I'm a very positive person. And what this does is that to assume that there's a causal effect relationship between the factors that affect outcome and the outcome itself. And when you're talking about realism and positivism, it means that it is an objective way, it is rational, and it is neutral. You can get objective answers from your work. If you look at what you say about self-administered questionnaire, you may think that you're talking about interpretivism, but when you talk about postmodern positivism, there's a possibility of content and construct and manipulation, validation that is in keeping with positivism. So in the real sense, it is about positivism. The other thing when you're doing this public health research that you really have to talk about is your positionality. How does my identity as Dr. influence my outcome or what the research brings out? And what do my perceptions bring into this space of this anesthesia? So you have to bring into a space where objectivity and subjectivity have to come out with the possibility of analyzing biases. So if you ask what influenced my positionality, I would say is my recurrent reading and my experiences as an anesthesia provider for many years, and the belief in me that surgery and anesthesia in this part of the world is not as safe as it should be, which was actually shown that you're more likely to have either morbidity or mortality if you have your surgery in a low-income country than in a high-income country for various factors which are beyond the scope of this talk today. So what were the results that we got? Oh, before there, I want to skip to this one. So the response rate was 97.5%. And I want to say thank you so much to all of you, because most of you were the same people I reached out to fill the questionnaire. And you did it very well and very quickly, because there was a time limit, as I had spent a lot of time trying to get ethical approval. So thank you so much for allowing me to achieve a 97.5% response rate. So when you look at the results, the independent variables that we were looking at, we looked at hospital beds, we looked at post-anesthesia care units, we looked at availability of oxygen, availability of water, availability of blood, and preoperative evaluation, safety checklist, and intra-op monitoring and mechanical ventilation post-operatively. And you can see there what the p-values were. So you can see these are basically all significant findings that were affecting the outcome of the surgeries. So if you look at the total number of cases done, out of 3,700 surgeries done in the period that we looked at, there were only 9 intraoperative deaths. And this was deemed to be like 0.1% relevant. And if you look at this, the availability of intensive care unit or high dependency unit or PACU, so you find that most facilities did not have an ICU that they could do mechanical ventilation. So that means they didn't have vents in their ICUs. Continuous monitoring, of course, was also low at about 50%. But most of the hospitals had an inpatient surgical ward, and most facilities had a PACU. So, but the important thing is that over 80% of all the facilities had a surgical inpatient ward, while only about 50% were able to continuously monitor their patients postoperatively in ICU or HTU, and about the same number were able to offer mechanical ventilation if patients needed it. So this is the other area that I found was a bit wanting, that only about 40% of all patients were evaluated by an anesthesia provider, whether the physician or non-physician. And if you look at the numbers that were not evaluated all the time, it comes to about 60%, which is a big number. And when you're talking about improving or giving access to safe surgery and anesthesia, these are some of the low-hanging fruits that as anesthesia providers we can pick, because there's no reason why we cannot move this 100% evaluation to about 80%. We know that there are people who will not be seen because of the nature of their work, but I think 41% is a bit on the lower side, and this is something that as anesthesia providers we can improve to probably improve the anesthesia care. The other thing that has been shown to improve the safety of anesthesia and surgery is the use of the WHO surgical safety checklist. And now this has been with us for a long time. So again, if we look at the number of facilities or number of cases where this was used 100% is about 20%. This means that we have a gap of about 80%, which gives us a very vast area of improvement. And I believe that if we were to move this number from 20 to about 80 or 90, then we will see our access to safe anesthesia and surgery also improving. And for these facilities that never use, so my challenge to all of us is to actually think about your facility where you practice and to see why is it that you're not able to use the WHO surgical safety checklist. What are the barriers to use? How can you, as a facility or as an operating room, overcome those barriers? Is it training you need? Then you can reach out to KSA, then we can organize those training. Is it acceptability? And all those things can be worked on. But this is one area where if we put our efforts together as anesthesia providers, we can easily get to 90 or at least 80%. That would make it. So the other thing is the use of intraoperative monitoring. So this is also quite interesting, that we are not reaching 100% for any of these continuous intraoperative monitoring. So if you look at the first bar, I know the lines are small. Can you see my arrow? Nganga, can you see my arrow?
Yes, yes, I can see your arrow, Daktari.
Okay, so the first block is about how often prophylactic antibiotics are given. And actually, if you look at 100%, we are below 30. So you wonder, why is it that we cannot achieve, at least for always, closer to 80%? When you come to the second space is how often is continuous pulse oximetry used intraoperatively, and we actually have less than 100%. This is worrying, especially because of the project that Lifebox has been running with the pulse oximetry. And it is interesting to note that it is not that well captured. When we look at tidal CO2, which in other parts of the world has become like standard of care, we realize that more than 50% never use it. And we know this is because of availabilities of the monitors. But this is where we are saying, when we get out of the operating room and get to these other sites, when we have data like this, then we can probably help the people who are making decisions to see where the gaps are. So when you think about this monitoring, yes, when you look at blood pressure measurements, we are reaching 80%, which is quite low. When you look at audible alarms, we are at 70%. So all these things are quite difficult to measure. And you see, ability to provide mechanical ventilation post-operatively, we have a big gap there. So we need to inform the decision makers. And this is where, because if you don't have a capability of ventilating these patients, sometimes by the time you leave where you are to go to where they can get ventilated, we have seen patients getting brain damage in the meantime. Then there is this question about how often a trained assistant is available. And the worrying thing is that almost always is, again, about 15%, which means that we don't have a way of ensuring. And one of the things that we have seen, even as KSA, the National Anesthesia Guidelines, we have highlighted that there's a need to have a trained assistant. And it's not nice to be in this scenario where we can have custom-made training scenarios, but like we have seen the challenges. There are some of these people who are very well trained, but when it comes to employment, the people who are in human resource or who are employing these people, they don't know where to place them. They don't know what job group. They don't know what their use is. So we need to get out of the operating room and actually advise these people what is the importance of this. So this thing about monitoring shows that there is a very big gap. But these are some of the things that we can easily plug and improve our quality and the safety of our anesthesia. If you look at a disconnect alarm, for example, and we are only using it at 70%, it is quite telling, because either it is not there, or people ignore it, or it has been switched off. And these are the small things that affect.
Dr. Gathuya, we seem to have lost you. Dr. Gathuya?
Sorry about that. I'm
Okay.
back on. You can hear me now?
Now I can hear you.
Okay.
Okay, thank you.
So I was saying that the use of intraoperative monitoring and these factors that we looked at actually show us that we have a very big opportunity to improve our anesthesia care and improve the safety of the same. So, so were the main things that I was looking at and seeing the things that we have opportunity to improve. So in terms of why is this of public health importance, is because when we have all the amount of surgeries that are happening, we have a complication rate of about 3 to 16% approximately. And of course, we have said that in our part of the world, the complication rates are much higher. So what does this mean? It means that approximately how many people are suffering from anesthesia? Yes. You have about 1 million people dying and about 7 million people suffering injury or morbidity from surgical related complication. This is a big number of people, and this is annually. So there is also the perception that many people thought that surgery or surgical care is expensive and attainable. And you think about something like maternal and child mortality and morbidity that is avertable by simple surgical interventions like a safe cesarean section. This means that if you can do that, if you can show that, and this is what the Lancet Commission set out to do. So in terms of, and this is how they look at the costs in public health. Then this is the daily averted by surgery, yeah, and this is the daily adjusted life years averted by surgery is about 19 to 102 USD, okay? And this is much cheaper if you look at it than a daily, the cost per daily of 350 to 1,494 USD averted by ARVs for HIV. That means that investment in surgery and anesthesia is comparable to other interventions such as immunization or vitamin A dispensation. So when you can show that these kind of interventions, when you can show that surgery and anesthesia can affect the outcome and the economic outlay without necessarily being too expensive, then it is something that we can sell, and then we can have investments into this space. And some of the investments that we are going to have, we are going to take them back into things like this, monitoring. Because then when you have monitoring, then you're getting better access. So even your cost per daily averted will be higher. The cost will be lower. You'll get more daily for a lower price. So, and some of the investments that we are looking at is this availability of ICU, mechanical ventilation, ICU, HDU, continuous monitoring, availability of PACU. So all these things that require investments can be pushed forward by showing that it is an effective investment in terms of the money spent, return on investment, like they call it. But that said and done, there are things like this that has to be our own initiative, our own work ethics that we are able to see and assess our patients before we bring them in for surgery. That we're able to use the WHO safety checklist, because this one does not require a lot of investments. If the barriers are training or acceptability, then the investment is a little to train people, to change their attitude, to show them exactly what is the importance of doing this. So some things will require investment, and some things will require us as the anesthesia providers to change and to improve the care of these patients. So in conclusion, there is need to strengthen the health system. There is need for us as surgical and anesthesia providers to get into that space of policy making, of decision making for the country, so that we can get these areas that are very important into the national priority. Remember when we started, I showed you for Kenya, at least, anesthesia and surgery are not part of the delivery priorities. Anesthesia and surgery are not part of the health objectives. Maybe by the time they do a next one, we can have a few of us into that space who can then push for this. And KSA is doing a good job at advocating. We must talk, we must advocate until people hear us and know that this is where we are, this is what we do, this is what we need to move this space forward. Improvement of processes, yes. Improvement of processes are those soft things, like being able to do your preoperative evaluation, being able to do your continuous monitoring, being able to have a very properly executed handover protocol, because sometimes handover protocols are what let us down. Am I doing my time, Ganga? I'm just about to finish.
You're doing very well. Continue, Dr. Gathuya. You're within your time.
Okay.
Yeah.
So, and then the other thing that now we need to work on is improvement of workforce and infrastructure. And I must say, for here, we've done well with COVID, because now most facilities are having or are going to get reliable oxygen supply. That is very important for our workforce. People have realized that there is need to train workforce. So we are going to have, at least the government is committing to train anesthesia providers, nurses, critical care workers, and all those trainings will help improve the space that we are at, so that then we know how best to move this policy forward. And with those few remarks, I must say thank you very much for listening to me. And I am open to take questions as we proceed. Over to you, Nganga.
Thank you, Dr. Gathuya. Thank you for this new, or rather reminding us about this very significant angle that most of us never get to look at or think about. That is the behind the scenes things relating to infrastructure, policy, resource allocation, and all that, all of which affect accessibility to safe anesthesia and safe surgery. It's quite interesting. I'm seeing a lot of my inbox is getting quite a very interesting chats from different people, and we'll discuss. We'll come to these ones in a few minutes once we get to the question and answer session. So at this point, I would like to give a few minutes to our partners, Novartis, to tell us more about themselves, and I'll invite Paul Sakwa, who is the institutions manager at Novartis, to take us through the next few minutes, and then after which we'll come to the question and answer session. Karibu, Bwana Sakwa.
Thank you very much. I will be sharing my screen. If you can see my screen, please let me know.
Dr. Gathuya, maybe you can stop sharing your screen.
So how do I stop?
Shell means maybe you can do that.
Oh, I've seen it.
Okay.
Is it off now?
Not yet. Still on. We're still seeing your conclusion. Okay, yeah, it's off now.
Okay.
Sakwa.
Yes. You can see my screen?
Yeah, we can see it now.
Thank you very much, Dr. Gathuya, for that very insightful discussion. Thank you very much, Dr. Nganga, for this opportunity. This time, I just want to first and foremost thank the entire KSF fraternity for giving us this time to have this, to partner with you on this occasion. So before I say anything, I want to recognize my colleagues who are online. I think there is Maureen Mukanga. Maureen, you're there? Maureen is the brand manager in charge of oncology range in East Africa. There's also Michael Irungu. Michael is a medical representative associate who is also in charge of the oncology range as well. So with that, I will just want to first and foremost then go into the discussion. I'll be very brief and just touch on the main points that I would want us just to ventilate upon. I was very interested, actually very happy also when I heard Dr. Ari talking about health system strengthening and universal healthcare, because at Novartis, I think going forward, one of our strategic imperatives is to ensure that we reach patients, we reach people, reach patients with our programs and reach patients with our products. And so even as we move forward, we have a number of programs that we are running today, which are very patient-centric. So for your patients who have undergoing operation and eventually they end up with post-operative nausea and vomiting, we have a product called Zofran, which is on Lancetron, which I believe quite a number of you guys on the call have interacted with the product. So Zofran is our brand of ondansetron, and it is original ondansetron. So basically for patients who have nausea and vomiting, we are saying that the incidence of PONV is quite high. After 80% of patients who undergo surgery will end up having this condition. And it's not usually very, it's not a nice experience. And so we have to ensure that these patients are taken care of. In some patients, up to 5 days after surgery, they still experience PONV. There are a number of things that would make a patient have this, and surgery is one of them. Basically for this discussion, surgery is one of the reasons why we could have a patient having this. And sometimes some of the anesthetic agents would also make a patient have experience PONV. There are other things up and including psychological factors. We have direct disturbance. We have even ideas to do things to do with disturbance of vascular apparatus. All these will give your patients PNV. But sometimes when you want to give this product, there are a number of things that you can look into, and history of the patient. And there's also the idea of non-smokers who are likely to experience PNV. And children are more, children are more prone to it than adults. And then, so we are also looking at then Zofran as a product. So we are talking about Zofran, which is indicated for prevention and treatment of post-operative nausea and vomiting. And as I said, Zofran is our brand of ondansetron, which is available, I think, across the Kenyan market. So basically, this is not for teaching, but just to ventilate on this, because the mode of action of the product that target PNV really affects a number of things, and up to including the side effects. So if it's a very potent, agonist, then there's a high likelihood that the number of things that are associated with it. So what is the right balance for the product to be more, so that the balance is there, so that there's no increased side effects of the product. So we are saying that in terms of binding, it is a very selective, high potent 5-HT3 receptor antagonist. But we are saying that for Zofran, it does not interact with other 5-HT receptors or receptors of other transmitters. So that is a very important point, because it then also says that this product is specifically very specific on the 5-HT3. I will not go into the details of this, because this is some of the things that these are, basic in terms of what we are looking at. So we have two modes of action, basically the GIT, peripheral, and the central nervous system, for which the Zofran tends to postulated mode of action. So in terms of what we have in the country, we have a number of formulations. We have the injectables, and we have the orals for your use. So Zofran, we have the 4 milligrams injection, and we also have Zofran 8 milligrams injection. So these are very useful, especially for your patients who require antiemetic given before operation. We also have the orals, which is 4 milligrams tablets. And we also have the Zofran Zydis, which is a self-dissolving tablet below the tongue. And so those are the 4 main formulations that we have in this country. So we have the 4 milligrams tablets, 4 milligrams dissolving tablets, 4 milligrams injections, and 8 milligrams injection that is available for your use. I would not go into the details of the pharmacokinetics, because I know these are some of the areas that we're looking at. But basically, the Zofran has a very predictable pharmacokinetics. And so you can easily predict in terms of the half-life, in terms of administration, and in terms of the maximum peak. So it's a very stable product. So for your patients, you can be assured that this is a very stable product in terms of the pharmacokinetics. So as I said, in terms of dosages, we are saying that usually you give 4 milligrams at induction of anesthesia. And in terms of treatment, we're giving 4 milligrams IV as a single dose. So the 4 milligrams at induction, usually in most cases, is able to deal with the PNV. But we're also saying that the dose is usually weight dependent. And so some patients, you might require to go up to 8 milligrams, especially when the patient has a weight that is above 60 kgs. So usually in children, I think also I would say that Zofran has a very good profile for use in the pediatric population. And so we can actually use Zofran for in children up to from 1 month up to 24 months, and 0.1 milligrams per kg as a single dose per kg. So you have to give per kg, and anything that is more than 40 kilos, you give 4 milligrams IV as a single dose. Yes, as I said, sometimes when you have very people who have much bigger weight, so you need to adjust the dosages so that you can give up to 8 milligrams in terms of for anesthesia, in terms of PNV. So you can give prior, after, or during the induction of anesthesia, or after surgery, so to cover for the patient with PNV. So this is also quite important because we are saying that Zofran has a very, it's actually quite safe in a number of populations. Renal clear, extensively metabolized, up to 5% of the dose reaches urine unchanged. We're also saying that there is no alteration of dose, especially if patients have renal impairment patients. So there's no need to significantly adjust the dosages because there's no alteration of daily dosages or frequency during administration for renal impaired patients because of this, because of the clearance. So this is also I'll not go into this because this talks about CNV. But when it comes to severe hepatic impairment, you have to make some adjustments because the product is highly metabolized through hepatic route. So we are saying that for these patients, you should not exceed 80 milligrams for administration if the patient has very severe hepatic impairment. So this is also very critical because we've seen products in the same category, same class as Zofran, having quite significant effect on the cardiovascular system. And so for Zofran, we are saying that Zofran has no effect on the cardiovascular system. The current studies show that there is no effect completely. There is no effect on the respiratory system as well. And it won't give your patients any sedation. So it's quite safe. And that's why a good number of pediatricians also would prefer to use Zofran during their procedures. And as I said, the same thing, that quite safe in terms of safety profile. And that's why it's quite, preferred in a number of patients. So we don't have a good data in terms of pregnancy use. We are also saying that it's not recommended in the first trimester, even though widely used in the market for other uses. We are saying that for mothers who are on Zofran should not breastfeed their babies. And so I would not go into this because this is just the administration. And so I would say that in summary, Zofran has shown very superior qualities or characteristics in the treatment of postoperative nausea and vomiting. And so in terms of efficacy, very efficacious. Safety, well tolerated across board. Different patients who have been given Zofran tend to tolerate it very well. We are saying also that it can be used across board from children and up to people who are aged, so they can be well used. Well tolerated, as I said, and we can be given as IV, IM, we have tablets, and the dissolving, self-dissolving tablets, the so-called Zofran. And I think, as I said, I started saying that vomiting has really impaired the quality of life. And by giving Zofran, I believe that this is a product that can really enhance patients' quality of life. So with those few remarks, just to back to my first slide, is that we have the 4 milligrams injection, 8 milligrams injection, 4 milligrams tablets, and the Zofran Zydis, which is very, very useful, especially for patients who have difficulty in swallowing. Usually works within 5 minutes or 5 minutes of administration, the Zydis. So thank you very much. I would want to open it up for any questions, any clarification that you could be having regarding Zofran. Thank you.
Okay, thank you, Paul, for that very insightful product presentation. Now we will go to the questions and answer session, and there are a couple of questions or comments regarding Dr. Gathuya's presentation, and we'll get right into it. First of all, a lot of the goodwill messages for stepping out of the theater, and which most of it's the comfort zone for most of us. But you have decided to venture out there into the public health aspect of it, which is quite a bold move. Now, the first question I would like you to respond to is coming from Dr. Lee Ngugi. Not because he's my friend and I know him, but also because it's a broad question touching on various aspects of your presentation. And he's asking, what is your take on the rolling out of the universal health care without emphasis on safety, mainly for both surgery, obstetrics, anesthesia care? Yet about 40% of the disease burden in this country falls under either of the category surgery, obstetrics, anesthesia. What's your take on that? I think while you're still at it, you can talk about resource allocation, whether it's the infrastructure, the ICU beds, oxygen supply, and the human resource aspect, and still affecting the safety aspect. I hope that was not too much. Dr. Gathuya?
Okay, I will try to answer that. Again,
Okay.
I said we have been too much in the operating room. And all these things require an appropriation of sorts. So if you're not, they say at the dining table, you're either the diner or the waitress or the meal. So we have to decide which of those ones we are as anesthesia and surgical practitioners. One of the major things in this country that we have seen is that a lot of our health decisions, policy, funding has been from not within the government. There's the Abuja Declaration that says that 15% of the national budget should be allocated to health. But we are very far from there. We rely on a lot of donor funds to do a lot of our health issues. So what is the direction of those donor funding? Because, they say he who pays the piper calls out the tune. So, and it has not been in surgery or anything like that. So what happens is that we must really get out to get into this space. Sometimes it is lack of knowledge. And I'm sure all of you who have been doing anesthesia for as long as I have done, and even longer, have had interaction with people who are very senior in government or in policy making, who have no understanding about what anesthesia is. Like I said the other time in my other talk, most patients will remember who their surgeon was, but not who their anesthesia provider was. So I think it is just a question rolling out UHC, the people who were there in the front line, drawing the roadmaps and the like, probably intentionally, probably not intentionally, because it didn't come to their mind, did not have this as a priority. And if they're using the documentation that we saw initially about the health policy and objective in this country, there's nothing about anesthesia and surgery. So I think that it all rolls back to there, that we were not diners at the dining table. We were probably waiters, if not the meal. So I think that is the first place that we must get back to. And we are hoping that now with the development of the National Surgical Obstetrics, Trauma and Anesthesia plans, that we will get these things in the forefront, that they will get funding, because it's mainly about funding. When I said that it has come as the silver lining on the cloud for COVID, is that with this facility assessment, there has been shed a lot of light on infrastructure and workforce. So when you talk about infrastructure and workforce, people have seen that you actually need to have oxygen. Some of the places that were running very high cases, there was actually an impending crisis because they didn't have oxygen, and this COVID is taking a lot of oxygen. And I think infrastructure for oxygen supply will help not only critical care, but also anesthesia, because mainly of theater. So I think to answer Lee is to say that the UHC, maybe it was not intentional, that they're rolling it out without inclusion of anesthesia and surgery and obstetrics, which form a big burden. But hopefully through KSA, through talks like this, maybe somebody is listening who can make a decision, and advocacy. The word is advocacy, consistent advocacy, so that we make our presence felt, so that, and then sell ourselves in a way that they see we are actually adding value. Because what happens most of the time in these places is that when you bring in something new, people are starting to look at budget allocation. This vote will come from and they want to be very mean with their votes. So there'll be no vote for that anesthesia. But I think when it comes to making the third midterm review for the Vision 2030, we really must make sure that we have anesthesia and surgery represented there. I think COVID has given us a good grounding for us to start. Resource allocation, again, I don't think we will achieve much until, number one, the government commits to provide money. In my talk, I said there is a perception that surgery is expensive, which is a perception. So we really need, again, to change that perception for people to realize that the cost for disability adjusted life years for surgical input is actually comparable to giving vitamin A or giving polio vaccine or whatever those other initiatives they do. And once we get people to realize that, then they will see that actually this is something that we can do. So it comes back to getting out of the OR, going to where this resource allocation is happening, and being part of that discussion so that we know where we are going. I don't know whether, Lee, whether I've answered your question. Lee, have you heard me?
Well, let's hope his silence means he's satisfied with the answer. Another question that keeps lingering on the chat is this question about the manpower. Someone, let me get his name, is asking about the workforce in terms of anesthesia providers, and he's asking the different categories, whether we have a scope scope of practice for the different cadres, from the physician, anesthesiologist, non-physician, nurse, anesthesia providers, and is asking whether we have a scope of practice and tasks and responsibilities. And also in line with that, what's your take on, now that the numbers for physician anesthesia providers is so down, is so low, and there has been this urge from some quarters to do short stopgap measures, like short course training in anesthesia, especially for areas that have no anesthesia providers. What's your take on that regarding safety?
Okay, about the roles and categories of what you can do, what you can not do, I think that is well covered within the curriculum when people are taught. But I think one of the things that is very good in our country is that we all train together, and we all form friendships. There are very many things that I was taught how to do by non-physician anesthesia providers. There are many things I have taught non-physician anesthesia providers to do. So I think rather than having very strict guidelines, is to work together, because there are some places that don't have that physician anesthesia providers. There are some scenarios where the physician was not able to secure the airway, but the non-physician came and helped, and they were able to secure the airway. So my urge would be, if we were to work together as a fraternity of anesthesia providers, the physician anesthesia providers will lead the way, set the guidelines, make sure the standards are okay. But in terms of practice, I think we should all be able to work together and know our limits from our training. We obviously appreciate that the physician is more trained than the non-physician anesthesia providers, even in terms of their background knowledge. So, and I think that is what we need to maintain, that the physician anesthesia providers maintain the lead. The non-physician anesthesia providers work together. We all work together as a team that is sharing resources, that is providing mentorship. I'll be very happy if a non-physician is in a place where they're not able to handle something and they call me. I'm in a different place, and I can probably help them deliver a safe anesthesia, rather than putting ourselves in silos, because those silos will only disintegrate fraternity that we are trying to bring closer together. So I think that is very, very important. And once we do that, then the issue of training comes in, because we know we are a long way to achieving what the WHO recommended ratios are for anesthesia providers. We hope that by starting CANESCA, we shall train more physician anesthesia providers, but it takes long, and we cannot be bury our heads in the sand and say that we cannot train this other people. The non-physician training program is actually very good. The one we know, the clinical officers, the nurse anesthesia providers, we just need to increase our capacity to train people. As for those short-term gaps where people imagine that you can train somebody for 5 days to give safe anesthesia, I am totally opposed to the idea. But again, you get these things pushed down your throat because you're so busy in the operating room, you don't know what is happening out here. And people are just doing their sort of things for whatever motivation. So for those ones, I think it is wrong. And one of the things that you should, for people who are thinking of doing such kind of training, is to ask yourself, if you are the patient on the receiving end of somebody who has received training for 5 days, what would your take be? If you had a choice, and you had the knowledge, would you present yourself to have anesthesia by such a person? And I think with concerted effort between the clinical officers, the nurses, and the physician anesthesia providers, And I think we are doing well in terms of increasing our numbers, but we must even do better. So that is my take on that.
Thank you. Thank you for that response. I'm trying to see the next question on the chat. I think the other question is regarding the fact that a lot of the challenges in safety in anesthesia and surgery in the region, in the East African region, look more or less the same. And someone is asking, are there like regional efforts to standardize approaches to these deficiencies in the region in terms of policy guidelines?
I think one of the things that we have done very well as a region is that because we have been few, we have managed to work together. We've worked with the people from Tanzania, from Uganda, from Zambia, Zimbabwe, South Africa. We've really worked well. I think now as the numbers become more and as we make this more formal, I think Connecta has a very excellent role in terms of ensuring that the standards of peace and care in all these countries are going to be the same. And once we work together as a college, then we will have policies and guidelines. Like now, I know Kenya has the national anesthesia guidelines. So then we will endeavor to make anesthesia guidelines for the college, which will not be very different from what the Kenyan ones are, because they borrow a lot from the international anesthesia standards for safe practice of anesthesia, which are developed by WFSA. But it is those collaborations and working together and interacting and having meetings like this where we have people from the region, within the region, that now within the college we can formalize and make those policies, those guidelines as a common platform that people can pick and adjust to their country of practice.
Thank you for that response. I'm trying to look for more questions. Not seeing any raised hands. The next question goes to Paul. Paul Sakwa, you still with us?
Yes, I'm online.
I think someone is still asking about Zofran and pregnancy or lactating mother, then availability and cost. I know someone is trying to answer on the chat, but maybe you can just do a quick comment. Cost, availability, suitability in pregnancy and lactating patients.
So I think, thank you very much for the question. I would say that as an organization, as a company, we do not have any data that has been used for pregnancy. And so the use in pregnancy is outrightly off-label. And so it's not in our promotion, and yes, it's not part of the education that have been approved for use.
Okay.
In terms of lactating mothers, yes, studies have shown that this product is traces of the product are in milk, and so it's outrightly also on our literature that should not be given to, or if mother is using it, then they should not lactate during that time of use. So that is the official standard position. And then in terms of availability, Zofran is widely available across Kenya and I would say East Africa. For all the SKUs or for all the available SKUs available across East Africa. So 4 milligrams, 8 milligrams injection and Zydis. Our official distributors in Kenya are Laborex and Sagifarm in Kenya. And so it's available in those at those places in almost all major hospitals, up to and including the public sectors. So in Aga Khan Hospital, Nairobi Hospital, and all the hospitals that have an operating theater, Zofran is available. Currently, we are not available in KNH, but we are working closely with the procurement and the physicians there to ensure that it's available in KNH. We also have, as currently, we also have an active program to make Zofran available in the public hospital. So most likely, one of these fine days when you are in the Mashinani hospitals, sub-count hospitals, you might find it there, because now we're working actively to ensure that Zofran becomes the standard product of use. And most likely when you ask for it there, you might get it. So we're working on that to ensure that it's available there. I'm sure if you ask for it in those places, they can actually be able to avail it, because it's widely available in the country. In terms of costs, currently a vial of Zofran 4 milligrams is 800 shillings, a vial of 4 milligrams, and a vial of 8 milligrams is 1350 up to the hospitals. So that is currently, and as I said, we are working also closely with the government entities to ensure that it's available there, most likely at an access price. Thank you. I hope I've answered most of the questions.
Sure, you have. Yeah, thanks for that response. I hope the answer is satisfactory to the persons who had asked. The other thing I would like to comment on is a couple of documents are available on the Kenya Society of Anesthesiologists website. These include the National Anesthesia Guidelines, because someone has asked about some of the things the society is doing to improve both access and safety in terms of practice of anesthesia. So you can visit the website and have a look at some of these documents, and hopefully they can answer some of the questions that one may have. I think we have.
Can I make a comment about monitoring?
Sure, please go ahead.
There are a lot of people who are asking why in the survey we didn't get 100% for SpO2 and all those things that are a bare minimum. But like I said, this was a very good response rate of 95.7%, 97.5%. And I was also surprised, but what I know or I figured out is that some people don't put monitors for very short procedures. Some people have ECGs, but they don't have dots, so they don't use them. They are small basic things. Sometimes everything is there, but they just don't use it. For a long time, I know people never used to take blood pressures in children. It's like children don't have blood pressure. And this is what I was saying about our attitude and our practice and our processes. Those things we can easily, and I'm very glad that people didn't cook the answers, so we were able to get what is actually true on the ground, that those monitors are not being used 100%. And I think it is not for lack of the monitors. I think it is just the way we use the monitors. There are people who, for some reason or another, will not connect monitors. Sometimes you connect the SpO2, because we saw the SpO2 is the one that has the highest level, but then they don't connect the other monitors. Either they say that the procedure is too long or whatever, is too short. But my urge to all of us is that if we have the monitors, let us use them. If we have the surgical checklist, let us use them. These processes, as we improve them, will improve our quality and safety for our patients.
Thank you. Thank you very much for that response. And I think our time is almost over. And I think I'm not seeing any more questions on the chats. I think I would like to take this opportunity to thank everyone, Dr. Gathuya, for making it possible to present, for a very nice presentation, a very detailed presentation on the public health aspect of access to safe anesthesia. Hopefully we'll have another time with you to deliver on the surgical aspect. I would also like to thank our partners, Novartis, for making it possible for this presentation to happen. Also to KSA, admin Shelmin, for hosting this webinar. I think I also want to thank all the participants from all over. I'm seeing Mubarak from Somaliland, Anthony from Zambia, and all the other guys from the larger East Africa. Thank you all for taking time to participate in this presentation. Thank you all, and let's meet next Thursday for another webinar. Enjoy your evening.
Thank you very much, everyone, for listening.
Thank you very much.